and anybody who would understand research. Hi, I'm Dr. Stuart Katz. I'm the Helen L. and Martin S. Kimmel Professor of Advanced Cardiac Therapeutics at the New York University School of Medicine, New York University Langone Medical Center. I'm the director of the heart failure program there. And it's my pleasure to be speaking with you this evening. I was born here in Manhattan. In fact, up in what's called Washington Heights. It was a very different neighborhood back then, mostly immigrant German Jews fleeing from the Nazi realm at before World War II, and that's where my grandmother went to in New York City, and I was born near her home in that section of the city. Well, that's pretty much sort of as long as I can remember. Had this idea. I probably credit my parents for planting that idea in my head. So even when I was a little kid, I remember when people say, "What do you want to be when you grow up?" And I would say, "A brain surgeon," and that'd be sort of shocking. So, but of course, I turned out to be a cardiologist, not a brain surgeon. It's hard to say for sure. I'll have to say that when I got into medical school, I actually had no idea what it was to be a doctor. I had volunteered in hospitals and in high school and college, so had been around doctors, had been around hospitals, and mostly volunteered with children. So I would help the kids play before their doctor appointments, before their tests or things like that. But I really had no idea what the doctors were doing in the hospital. So it was just by luck that as I got into it, I realized it was really something I enjoyed very much. And a nice thing about the field of medicine is that there's a variety of different environments that you can wind up practicing in. So I was attracted to cardiology because that was a field of medicine that at the time was rapidly evolving new treatments that seemed to provide sort of amazing benefits to patients, and that really attracted me into that field. Well, again, it's sort of going back in a historical way. About 25 years, there was a growth in the 1960s and 1970s, the creation of coronary care units for treatment of patients with heart attacks. And the main innovation in those early years was a defibrillator. Everybody knows about the paddles to put on the patient's chest. And the idea of the CCU was to have trained personnel near the patient having the heart attack in case they needed to have that defibrillation to save their life. But in the 80s and 90s, there began development of more types of interventions that could actually interrupt a heart attack, sort of stop a heart attack from happening, so that you wouldn't even need the defibrillator. You'd be able to really just save the person's heart. And that's what was going on when I was in my training. And as you can imagine, that was sort of amazing to witness, to see these things in action. And so that was really the thing that attracted me. I studied in the Northeast of the U.S. I did my medical school in Brooklyn, New York, at the state school called Downstate Medical Center. After that, I went down to Baltimore, Maryland. I was at a hospital that's had several names. It was called Baltimore City Hospital when I was there, but it was since purchased by Johns Hopkins, and now it's called Bayview Medical Center. And that's where I did my internal medicine training. I came back to New York into the Bronx, Albert Einstein College of Medicine, and that's where I did my cardiology training. After I graduated from that program, I spent a few years at Albert Einstein and then moved to Columbia College of Physicians and Surgeons, or New York Presbyterian Hospital. I spent 10 years there, working in my subspecialty interest of heart failure. In 2001, I went to Yale University, New Haven. That's sort of the furthest I've ever, sort of practiced away from New York City. I spent 7 years there, and then 5 years ago, I came back to New York at New York University. first got involved in research in medical school, I was interested in control of blood pressure, which was sort of related to cardiology, but I was actually working with some nephrologists, some kidney doctors at the time. So kidney is also important in the control of blood pressure. And during my training in Baltimore, I did some work at the National Institute of Aging, which was immediately adjacent to my hospital. And that was basic research on how blood vessels age, how they change with aging. And that led me to understand that I didn't really enjoy the basic research that much. I enjoyed it, but I missed the contact with the patients, because you really just, when you're in a laboratory environment, you're just working with your coworkers and the laboratory animals. So when I finished my medicine training, I had different opportunities for research, but I had a strong feeling that I wanted to go to what's called clinical research, meaning working with patients, with human subjects who volunteer to be in research studies. And I was really very fortunate, and anybody who's interested in research is always strongly influenced by mentors that they meet along the way. And when I got to Albert Einstein College of Medicine, I was very fortunate to have two important mentors in my life, Terry Legemtel and Edmund Sonnenblick, two cardiologists who were at that institution. And Dr. Sonnenblick was a senior cardiologist who had started what I would call the modern understanding of how the heart works in very, very important work that he had published in the early 1960s and had continued up until the time that I was working with him. And he and Dr. Legemtel had a very robust clinical research program that was directed at trying to understand what made patients with heart failure feel sick and how to make them feel better. And again, that was, the part of the thing that attracted me to cardiology, that we seem to be able to use medicines in a way to really make patients feel better, and this was another opportunity for that. So that led me down several different avenues of investigation. But as I became more experienced, it also occurred to me that while we've made great strides in treating patients with heart failure really is a disease that's sort of the end consequence of other heart diseases. It's like the last stage of different heart diseases. And so I really got interested in trying to understand more about preventing heart failure. And one of the more common causes for heart failure is heart attacks. So getting back to heart attacks. So even though we've developed technology over the past 20 years to be able to interrupt heart attacks, it only works for the patients that get to the hospital quickly. And at about 30% of the heart attacks, they're considered silent, meaning that the patient might not even have chest pain, so they might even not know that they're having a heart attack. They might have some other discomfort but not realize that it's a heart attack. And other patients, despite all the information that's out there, it's just don't get to the hospital in time. So heart attacks are still very common, and many of the people who have heart attacks wind up developing heart failure, either over at that time or years down the road. So heart attacks are related to a blood vessel disease called atherosclerosis, which is the buildup of plaque inside the walls of the coronary arteries. And I became interested in something called the iron hypothesis. So the iron hypothesis is based on the observation that women who have menopause start to develop an increased risk of heart attack over about 10 years after menopause. And for many years, people thought that increased risk was due to changes in the hormonal cycles in women at the time of menopause. And in fact, that led to studies where they gave women estrogen supplements after menopause with the idea that would prevent heart attacks. And those studies turned out to show that there was no benefit to taking estrogen. So the alternative hypothesis was that it's not the change in the hormones at the time of menopause, but it's actually the cessation of menstrual bleeding. so that over about 10 years after cessation of menstrual bleeding, the iron stores in the woman's body builds up to about the same levels as men of the same age. And so the theory is that it was the iron building up in the body that's really increasing the risk of heart attack in these women. And if you look through a lot of literature of population-based studies, epidemiological studies, there's a pretty good association between various measures of the iron stores in the body and the risk of having heart attack and stroke. It's not perfect. Many of the studies show a positive association, a few of the studies don't. And the part of the medical literature that caught my attention the most was that related to blood donors. So iron metabolism is such that iron can get into the body through our diet, but there's no way for it to get out of the body. There's no natural mechanism for excreting iron. So whatever iron you take in pretty much stays in your body. The only way that iron leaves your body is through bleeding. So blood donation is a natural experiment where people voluntarily decide, I'm going to give up some blood, and in that process they're really giving up their iron. And the studies that looked at the blood donors showed that the more blood they gave, the lower their risk of heart attack and stroke. But it was hard to interpret these studies because of something called the healthy donor effect. So if you say to yourself, well, who gives blood? And who gives more blood than other people? And of course, there's a lot of factors that go into that, but part of the factors is that somebody who gives a lot of blood has to be healthy enough to give a lot of blood. So maybe it's not because they're losing their iron, maybe it's just because it's selecting out healthy people who are going to not, to do well no matter what their behavior was with regard to blood donation. So we are doing a study that's trying to answer that question by actually doing blood donations, but in half the people, after the blood donation, we actually give them back the iron that they just lost in the blood. And you can give that through an intravenous, through an IV. And we're looking at the effects of those changes in iron on the blood vessel function. And we're hoping to see whether there's a signal between losing blood and losing iron that's more beneficial than just losing the blood but getting the iron replenished. And if that's true, it would help us move forward and perhaps do much larger studies in blood donors or perhaps in postmenopausal women. And it could have an impact on public policies regarding iron supplementation. So every time you eat bread that's made with flour, all the flour in the US and I believe in most of the world is fortified with iron for reasons that are not quite clear. That the idea is more iron is good, and that may not be the case. So we're actually just getting towards the end of this project, and we're very excited about finding. It's been 5 years, so we're very excited about finally getting some answers. Well, the book is written as is about heart failure, the diagnosis and management of heart failure, and the book is written as a practical guide for clinicians who are taking care of patients with heart failure. And the genesis of the book was that there are practice guidelines published by medical societies that examine all the evidence in the medical literature and make recommendations to physicians about the treatment of certain diseases, heart failure included. And these are published by these medical societies and medical journals and updated every few years as new evidence becomes available. But the format of those guidelines are not really in the order that's most helpful to someone who may be seated across the table from a heart failure patient. So the idea was to create a guide that sort of used the same information that's available in the guidelines, but to set the order of that information to follow the natural flow of patient care, so that if a clinician was taking care of a patient with heart failure, they would be a useful resource. It's also short, that they'd be able to quickly look up in that part of the book that would match what they were doing that day in that patient, and they'd be able to get some answers quickly for managing that patient in any given situation. Right, so the book is organized to follow the flow of the way that a clinician would actually encounter a heart failure patient. So it starts off by defining heart failure, because you have to know what you're talking about for the rest of the book, and there are actually different types of definitions for heart failure. So we go through the different definitions and try to say, well, this is what we're talking about here. And that's the basis for the next few chapters, which really are talking about screening for heart failure, identifying heart failure patients, knowing that you've actually found a patient who has heart failure. And then there's strategies for preventing heart failure. So a lot of doctors in primary care especially are managing patients who have high blood pressure and risk factors for coronary artery disease. So high blood pressure and coronary artery disease account for almost all the heart failure that we have in our country. So if clinicians were better able to help their patients and manage their blood pressure, reduce the risk factors for heart attack, we theoretically could prevent a lot of the heart failure that we see today. So that's a big part of it, and trying to identify the patients at the greatest risk where you can focus most of your efforts. And then the rest of the book takes the heart failure as it progresses through its various stages. So heart failure can start as either an asymptomatic or mildly symptomatic disease, and over a period of months or more typically years, the symptoms can get worse and worse until patients with advanced heart failure may have trouble doing simple activities like getting dressed or taking a shower in the morning. So the idea is that there's specialized approaches to management at all these different stages. So we take each of the stages and talk about that. And then finally we talk about what to do with the patient if they actually wind up in the hospital, both in terms of the care that happens in the hospital, how to get that patient feeling better again, and then also very importantly, what to do about that patient after they leave the hospital, because once a patient's gotten sick enough to require hospitalization, that patient's actually at great risk for a second hospitalization and even death. So that identifies a patient where you really have to make your best efforts to turn their care around and try to reduce the risk of those events in that patient. Right, so it's one of the more common questions I get from patients. And unfortunately, my answer probably is not exactly what people want to hear. What I would say is that a big part of prevention of heart failure is not so much nutritional supplements. It's more about what you should not be eating. So you should not be eating saturated fats, you should not be eating heavily salted diets. And the recommendations of the American Heart Association for heart healthy diet are those essentially replicating what's called the Mediterranean diet. So using olive oil as the primary fat in the diet, putting emphasis on more fruits and vegetables in the diet, less red meat, more fish and chicken in the diet, more nuts and whole grains in the diet. These are all things that have been shown to be associated with reduced risk for heart attack and better blood pressure control, less obesity, and these are all the manageable risk factors based on lifestyle modification that can reduce the risk of heart failure. I will say that for patients who have developed heart failure, we do recommend a low sodium diet, less than 2 grams of sodium a day, which is about 1 teaspoon. And the way to do that is to rely on freshly prepared foods, not pre-prepared foods from cans or other containers, and to pay attention to the salt content, which is on the label of all the foods, and to stick with foods that have less than 200 milligrams per serving. That's a good way to stay under 2,000 milligrams a day. There is some information about coenzyme Q10. Coenzyme Q10 is a cofactor that's important for energy metabolism and regulation of proteins throughout the body, including the heart. And there was a recent study it's published, it was not published yet, I take it back, it was presented at European meetings just this past year. And it was probably the best study yet done with coenzyme Q10. And what they showed is that a pretty large dose, I believe it was 300 to 400 milligrams a day of this supplement, was associated with improved heart function and even improved survival. And this was in several hundred patients with heart failure. So based on that study, I think there's some cautious optimism that coenzyme Q10 is a nutritional supplement which might actually be useful in heart failure. But I would also say that from the standpoint of this relatively small study, it's not absolute proof. So if coenzyme Q10 were a drug made by a big drug company, this study would be considered a pilot study that might lead to much larger studies. But because coenzyme Q10 is considered a nutritional supplement, it's not held to the same standards. And part of that is that there's no known side effects of coenzyme Q10. So at this point, there's no clear downside other than its cost, because to take 300 or 400 milligrams a day is actually fairly costly. But at least this one study suggests that there might be some benefit as a nutritional supplement. So if a patient asks me about it, I won't discourage them from taking coenzyme Q10. Right, so I think it's important if any body watching this video has heart failure, knows someone who has heart failure, and that's very possible. It's a common disease. Above the age of 80, about 1 in 6 people have heart failure. So if you're above that age, either you have it or you know somebody who has it, and many people have parents who have this disease. It's very common. So what I would say is that the most important thing to be aware of is what we call the functional capacity. So if you're still able to walk several blocks or 2 flights of stairs, if you're able to complete your normal chores and be able to run errands, those are all good signs. That said, there are medicines that are available that not only help patients feel better, but also keep them from getting worse over time. So even if you're feeling pretty good, it's still worth going to your doctor and making sure you're getting all the right medicines to keep the disease from progressing over time. As the disease does progress, the ability to do those normal activities gets less and less. And for people who've never had heart failure, it's really, most people have had the experience of if they run, let's say they're running to catch a bus or running too far or too fast, and you'll get this feeling of being out of breath and being tired, and your body will sort of tell you better stop. And heart failure is sort of the same feeling, except it can occur just walking across a room. So if you can imagine getting that kind of terrible feeling with just a small amount of effort. And for those patients, there are medicines that can help them feel better. They should definitely be talking to their doctor about what they can do to help themselves. And depending on their circumstance, some patients, if they're not getting adequate relief from the lifestyle modifications we talked about and diet, there are other more what we call advanced therapies, including special kinds of pacemakers that can sometimes help. Even mechanical pumps. This is Vice President Cheney had this pump. He was recently featured on 60 Minutes talking about a mechanical pump that essentially saved his life. And then heart transplantation is, which also Vice President Cheney received a heart transplant, and he, at the age of 71, feels like he has a new lease on life. So it's important for patients to recognize that this is a treatable disease, it's not a hopeless situation, and they need to be seeking appropriate help. Right. So I'll answer that question on a long-term horizon, and that's really part of regenerative medicine, which is the idea of using some sort of stem cell to repair tissues. So we know that in the human body, certain tissues can repair themselves. So if you cut your skin, it can heal and pretty much go back to like new. So you don't see the cut anymore. The liver can regenerate itself. The kidneys can heal and regenerate themselves, but the heart can't naturally. So the idea is to understand what's the difference between the heart and some of these other organs, and try to come up with a way to essentially allow the natural processes that allow other organs to heal themselves to also allow the heart to heal itself. And there's been some great strides in our understanding of the way that stem cells work over the past 10 years. But because the heart is such a complicated organ, I don't see any major breakthroughs in this type of regenerative medicine for in the next 5 years. But maybe in the next 10 to 20 years, I do think that there will be some major breakthroughs in the way we approach patients with heart failure. And yeah, our goal is to be able to use some sort of regenerative medicine to restore the normal function of the heart without the need for a transplant. And that would essentially cure the heart failure condition. So right now it's a treatable, but short of heart transplant, not a curable condition. And the goal over the next 20 years is to turn it into a curable condition. Well, I always try and give a hopeful message to my patients, because I do believe there's a lot of things available to offer. So it can be very depressing and discouraging to have heart failure. Imagine waking up every morning, sort of feeling tired, going to brush your teeth and actually getting out of breath. These are very difficult things some of our patients have to live with. So I try to emphasize that there are lots of good treatments out there, and they have to find good doctors who can help them, and they have to do what they can to help themselves.
Thank you so much.